Thank you to IDSOG for the privilege of presenting our study, Lactate and Procalcitonin Levels in Peripartum Women with Intraamniotic Infection. I'm Dr. Samantha Do, and this study was my maternal fetal medicine fellowship project at Stanford University. My primary research mentor is Dr. Natalie Aziz. Our study team consisted of Dr. Haley Miller, Dr. Stephanie Leonard, Dr. Imee Talk, Dr. Anna Gerson, Dr. Shanti Kampagoda, and Dr. Ronald Gibbs. Funding was generously provided by the Stanford Center for Precision Health and Integrated Diagnostics, who awarded a C grant but otherwise had no role in the study. Outside of pregnancy, lactate and procalcitonin are used to assess and manage severe infections, but data on their utility in labor is limited. Our objective was to determine if lactate and procalcitonin are elevated with peripartum infection and if they could thus contribute to the management of infection in labor. This was a prospective observational cohort study performed from January to December 2019 at Lucile Packard Children's Hospital. We included women 18 years or older with singleton gestations at term who were admitted either in early labor with planned vaginal delivery or for induction. We had two study groups, the uninfected group and the intraamniotic infection group, or IAI group. Lactate and procalcitonin levels were drawn and compared between women with and without IAI at 3 time points: 1, early labor; 2, within 2 hours following delivery; and 3, postpartum day 1. Lactate and procalcitonin were also drawn within 2 hours following diagnosis of IAI. The primary outcome was the difference in lactate levels between women with and without IAI, drawn within 2 hours following delivery. Study enrollment was powered based on results from prior literature, with alpha 0.05, power 80%, and a difference in lactate of 1 millimole per liter, measured within 2 hours following delivery, between women with and without IAI. We calculated the study would require 12 women per group, and recruitment was performed until at least 12 women with vaginal delivery were enrolled in each group. Comparisons based on infection status were performed using linear regression models with log-transformed lactate and procalcitonin values, and adjustment for maternal age, race, ethnicity, BMI, health insurance status, gestational hypertension or preeclampsia, labor induction, gestational age, and parity. Models for postpartum time points were additionally adjusted for time since delivery, mode of birth, and postpartum hemorrhage. Baseline characteristics were similar between both groups, including race, ethnicity, insurance status, and comorbidities. Looking at the top table, lactate levels were normal in early labor in both groups. Lactate levels were elevated at delivery at 2 in women without infection and 2.33 in women with infection, and reported to normal by postpartum day 1 for both groups. For our primary outcome, the difference in lactate at delivery between women with and without infection, there was a small significant difference found in the unadjusted model that did not persist after adjusting for confounders. Lactate levels also did not significantly differ at the other time points in either unadjusted or adjusted models. In the bottom left graph are the individual values of lactate at delivery in the uninfected group on the left and the infected group on the right. Box plots show the medians and interquartile ranges, and the red line at 2 is the threshold used in non-pregnant adults for an elevated value. Notably, this shows the physiologic rise of lactate in labor, with a significant portion of uninfected women on the left having lactate levels elevated above 2. Looking at procalcitonin, in the table second from the top, levels rose following delivery in both groups, but were approximately twice as high at delivery in women with IAI compared to uninfected women. This difference was significant, with p of 0.03. Postpartum procalcitonin continued to rise in women with and without infection compared to levels in early labor and at delivery. In the bottom right graph are the individual values of procalcitonin at delivery in the uninfected study group on the left and the infected study group on the right. There is a significant difference in the levels of procalcitonin between infected and uninfected women. However, at delivery, most patients in both groups had procalcitonin levels in the normal range, below the threshold for bacterial infection outside of pregnancy of 0.25, marked by the red line. One limitation of our study is that we investigated the correlation of lactate and procalcitonin with IAI as more common than sepsis, which allowed the study to be feasible. Additionally, we were not powered to detect a difference less than 1 in lactate. While there may be a statistical difference found with a larger sample size, an effect size of less than 1 may not be clinically relevant. In conclusion, consistent with prior work, we found that lactate rises physiologically in labor without infection. A novel finding was that lactate is not a clinically reliable marker of infection in active labor or immediately postpartum, as lactate is not meaningfully elevated with infection above its physiologic rise. But the normal threshold for lactate of 2 appears appropriate for assessing infection in early labor and by postpartum day 1. Another novel finding of our study is that procalcitonin is elevated at delivery and postpartum with IAI compared to without infection. However, the physiologic rise of procalcitonin on postpartum day 1 is higher than its elevation with IAI at delivery. Thank you for your time.